Sjögren syndrome ranks among the most commonly misdiagnosed autoimmune diseases in the world. But here are 5 things that commonly surprise people about what Sjögren's can do to the brain. Most people think Sjögren's is just dry eyes, dry mouth, maybe fatigue that never fully goes away. And if that's all you've been told, what you're about to hear may genuinely shock you. Because researchers and neurologists who specialize in autoimmune disease have documented something that almost never reaches the patient. Something that changes the entire picture of what Sjögren's actually is. This disease can attack the brain directly. It can trigger seizures. It can cause lesions that show up on MRI scans. It can produce psychosis. It can cut the connection between your brain and your heart. And it can silently destroy the nerves that control your ability to swallow and breathe, while you are still trying to get someone to take your dry eyes seriously. This is not worst-case scenario content. This is documented. This is real. And most patients living with Sjögren's have never been told any of it. If you have Sjögren's, if you suspect you have it, or if someone you love has been diagnosed, stay with this entire video. Because what you're about to learn may be the most important information you have ever encountered about this disease. Hit subscribe and leave a like. That helps this channel reach more people who need it. The goal at Health Insight is 200,000 subscribers, and every single person who joins moves us closer. And if you want the full Sjögren's symptom map guide with visuals, symptom breakdowns, and additional resources, type symptom map in the comments and I'll send you the link to access it. Number 1. Sjögren's can cause seizures and stroke-like episodes, and it gets misdiagnosed as MS for years. You suddenly notice something that doesn't fit the usual picture of Sjögren's. An episode of confusion so severe it frightens the people around you. A moment where one side of your body stops responding. Sudden vision loss. A seizure with no prior history of epilepsy. A neurological event that comes without warning and leaves you changed. And when it gets investigated, something extraordinary happens. The scans show abnormalities. The neurologist looks at the pattern and says the word that changes everything: multiple sclerosis. Except it isn't MS. In Sjögren's, the immune system can cross a line that most patients are never warned about. It can attack the central nervous system directly, not the moisture glands, not the joints, not the peripheral nerves at the surface of the body, the brain itself. This is called CNS vasculitis, or central nervous system involvement in Sjögren's, and it is one of the most dangerous and most consistently misidentified complications of this disease. What happens is this. The same autoantibodies circulating in the bloodstream, the ones driving inflammation throughout the body, can breach the blood-brain barrier. Once inside, they can inflame the blood vessels that supply the brain. When those vessels become inflamed and narrowed, blood flow to regions of the brain becomes compromised. The result can be transient ischemic attacks, episodes that look and feel like small strokes, or full cerebrovascular events, or seizures, as the inflamed brain tissue becomes electrically unstable. And because the MRI findings in CNS Sjögren's can look almost identical to the lesion patterns seen in multiple sclerosis, patients are misdiagnosed and placed on MS treatment protocols for years. The underlying autoimmune driver, Sjögren's, continues unchecked. The neurological damage continues accumulating. And the patient gets sicker on a treatment pathway designed for the wrong disease. This is why it gets missed. Because the presentation is dramatic enough to demand urgent investigation, but the investigation follows the most visible pattern rather than the underlying cause. Because Sjögren's is not the first thing a neurologist reaches for when someone presents with stroke-like symptoms. Because the autoimmune connection requires someone to look past the obvious and ask a harder question. This is where people lose years. This is where the neurological trajectory changes permanently because the root cause was never identified. You were not having panic attacks. You were not catastrophizing. If you have ever experienced a neurological event that felt disproportionate to what anyone was willing to explain, your instinct that something deeper was happening may have been exactly right. Type seizure in the comments if this is the first time you are hearing that Sjögren's can do this. Because most patients find this out far too late. But it doesn't stop there. Number 2. Sjögren's leaves visible marks on the brain, white matter lesions that appear on MRI. You suddenly learn something in a consultation that nobody prepared you for. Your MRI came back abnormal. There are white spots. Lesions on the brain. And the radiologist's report uses language that sends you into a spiral of fear, because those same words appear in descriptions of MS, of early dementia, of neurodegenerative disease. And you are sitting there with a Sjögren's diagnosis wondering how dry eyes led to this. Here is what is actually happening. In a significant proportion of patients with Sjögren's, particularly those with central nervous system involvement, MRI imaging reveals white matter hyperintensities. These are areas where the brain tissue has been damaged. Not metaphorically. Not functionally. Structurally. The brain is visibly, measurably changed. These lesions form because of the same process driving the rest of the disease. Chronic inflammation. Immune-mediated damage to the small blood vessels supplying the brain's white matter. When those vessels are repeatedly inflamed, the tissue they supply begins to deteriorate. The myelin, the protective coating around nerve fibers, breaks down. The signals those fibers carry become disrupted. And the evidence of that disruption shows up as bright white spots on an MRI scan. What makes this particularly devastating is the silence of the process. White matter lesions accumulate over time without producing symptoms dramatic enough to trigger imaging. A patient can be living with progressive structural brain changes for years while the clinical picture remains, on the surface, manageable. By the time the lesions are found, often incidentally, or during a workup for something else, the accumulation is already significant. And the cognitive symptoms that these lesions produce, slowed processing, word-finding difficulty, problems with attention and memory, are so commonly attributed to fatigue, depression, or aging that nobody orders the scan that would show the structural explanation. This gets missed because white matter lesions have many causes and Sjögren's is rarely the first one considered. Because the connection between an autoimmune exocrine disease and structural brain changes requires a level of systemic thinking that doesn't always happen in routine clinical care. Because patients are not routinely offered neuroimaging as part of their Sjögren's management. This is where the damage becomes irreversible. White matter lesions do not disappear. They accumulate. And the neurological function they represent does not fully return. Neurological damage can progress quietly. The longer this is ignored, the harder it may become to manage. This is where people lose critical time. But here is what this means for you right now. If you have Sjögren's and you have never had a brain MRI, you do not know what is happening inside your central nervous system. That is not a statement designed to frighten you. It is a clinical reality that your care team may not have addressed. You're not imagining the cognitive changes. There may be a structural reason visible on imaging that nobody has looked for. Type lesions in the comments if you have had an abnormal MRI and nobody connected it to your Sjögren's. Because this connection is being missed every single day. And this is where it gets frightening. Number 3. Sjögren's can cause psychosis, hallucinations, paranoia, and complete breaks from reality. You suddenly hear something that reframes an episode from your past, or from the past of someone you love, in a way that is almost impossible to process. A patient with undiagnosed Sjögren's begins hearing things that aren't there. Seeing things. Believing things with absolute certainty that have no basis in reality. They are admitted to a psychiatric facility. They are given antipsychotic medication. They are given a psychiatric diagnosis that will follow them for years. And the autoimmune disease driving the entire episode is never identified. This is autoimmune encephalitis associated with Sjögren's syndrome. And it is one of the most documented, most consistently misidentified, and most treatable neurological emergencies in autoimmune medicine, if it is caught in time. Here is the mechanism. In some patients with Sjögren's, the immune response extends beyond the typical autoantibodies and begins producing antibodies that target the brain tissue directly. These neuronal antibodies can attack the receptors and proteins that regulate brain function, including the systems governing perception, cognition, and the boundary between internal experience and external reality. When those systems are disrupted by immune attack, the result is psychosis. Not metaphorical confusion. Clinical psychosis, hallucinations, paranoid ideation, severe behavioral change, complete dissociation from reality. Anti-NMDA receptor encephalitis is perhaps the most well-known of these antibody-mediated encephalitides, but Sjögren's has been associated with multiple neuronal antibody profiles. The presentation can include psychiatric symptoms so dominant that the neurological origin is entirely obscured. The patient goes to psychiatry. Psychiatry treats the symptoms. The autoimmune attack on the brain continues. Because psychiatric presentations get psychiatric workups. Because autoimmune encephalitis requires specific antibody testing, that is not part of any standard psychiatric admission protocol. Because a young woman presenting with sudden onset psychosis does not immediately trigger a Sjögren's investigation. Because the disease that started with dry eyes is not in the room when the psychiatric history is being taken. This is where people lose years to the wrong diagnosis. This is where families watch someone they love deteriorate through a revolving door of psychiatric care, while the treatable autoimmune cause goes unaddressed. But when autoimmune encephalitis is identified and treated, with immunotherapy targeting the underlying immune dysfunction, patients can recover. Sometimes dramatically. Sometimes completely. The window matters. This is where people lose critical time. Because the longer the immune attack on neuronal tissue continues, the less reversible the damage becomes. You are not losing your mind. And if you have ever experienced a psychiatric episode that felt disconnected from everything else in your history, or if someone in your life has, the question of autoimmune origin deserves to be asked. Type psychosis in the comments if this is the first time you have ever seen this connection made. Because it is one of the most urgent and most invisible intersections in all of autoimmune disease. That's not the real problem. Number 4. Sjögren's can sever the connection between the brain and the heart. You suddenly find yourself on the floor, or gripping a wall, or coming back to consciousness with no memory of the seconds before. Your heart was racing at 200 beats per minute for no reason. Or it stopped, briefly, in a way that your body registered as absolute terror before it started again. And every cardiac test comes back normal. Every Holter monitor. Every echocardiogram. Normal, normal, normal. And you are standing in a cardiologist's office being told that what you experienced was probably anxiety. But it was not anxiety. In Sjögren's, the autonomic nervous system, the network of nerves that operates below conscious control and regulates the heart rate, blood pressure, and circulatory response to every movement you make, can become a target of immune-mediated damage. Specifically, the cardiac autonomic nerves. The nerves that tell your heart how fast to beat when you stand up. The nerves that manage the vascular tone that keeps blood pressure stable when you change position. The nerves that form the biological infrastructure between your brain and your cardiovascular system. When those nerves are attacked, when immune-driven inflammation disrupts the signals traveling between the brainstem and the heart, the result is a condition called cardiac dysautonomia. And its presentations can include postural orthostatic tachycardia syndrome, where standing up triggers a heart rate surge that is physiologically indistinguishable from a panic attack. Vasovagal syncope that occurs with no identifiable trigger. Sudden bradycardia. Episodes of near collapse that leave the patient and everyone around them terrified. And because cardiac dysautonomia is not found on a standard ECG. Because the tilt table test that would document it is not routinely ordered. Because the connection between an autoimmune disease affecting the exocrine glands and damage to the cardiac autonomic nerves requires a diagnostic leap that most cardiologists are not trained to make, it gets missed. Over and over. For years. Sometimes for decades. This is where the disease stops feeling manageable. This is where patients stop driving. Stop going out alone. Stop trusting their own bodies in public spaces. Because the unpredictability of cardiac dysautonomia imposes a kind of house arrest that is invisible to everyone else. Your heart was not behaving erratically because you were anxious. Your autonomic nervous system may have been under immune attack. And there is a test, a tilt table test, an autonomic function study, that can document what every other cardiac test has missed. Type heart in the comments if you have been told your cardiac symptoms were anxiety when something deeper was happening. Because this is one of the most disabling and most dismissed complications of neurological Sjögren's. But it doesn't stop there. Number 5. Sjögren's can silently destroy the nerves that control breathing and swallowing. You suddenly notice something that frightens you in a way that is hard to explain to anyone. Food goes down wrong more often than it used to. Your voice has changed, hoarser, weaker, different in a way you can't quite describe. Sometimes you wake in the night with the sensation of choking. Sometimes you feel like you can't take a full breath, even when your lungs are clear. And every test comes back normal. Pulmonology clears you. Gastroenterology finds nothing structural. Your Sjögren's team is focused on the glands, the dryness, the joint involvement. Nobody is looking at the cranial nerves. In Sjögren's, the immune system can target the cranial nerves, the 12 pairs of nerves that emerge directly from the brain and brainstem and govern the most fundamental functions of the head and neck. Among these, The vagus nerve, the 10th cranial nerve, is the most consequential target. The vagus nerve controls swallowing, vocal cord function, the gag reflex, the cough reflex, heart rate regulation, and the muscular coordination of breathing. It is, in many ways, the most important nerve in the body. When Sjögren's-related inflammation damages the vagus nerve, the results are not subtle once they fully manifest. But the early stages are. The early stages feel like acid reflux. Like a slightly changed voice. Like occasional difficulty swallowing that comes and goes. Like not quite being able to clear your throat. These early symptoms are so easy to rationalize, so easy to attribute to other causes, that the progressive nerve damage driving them continues unrecognized. Cranial nerve involvement in Sjögren's also extends to the nerves controlling eye movement, facial sensation, and hearing. Trigeminal neuropathy, damage to the nerve governing facial sensation, is one of the most documented and least discussed cranial nerve complications of this disease. It can produce numbness, burning, or pain across one or both sides of the face that is routinely misdiagnosed as dental problems, sinusitis, or atypical facial pain disorder. Because cranial nerve symptoms are assessed by neurologists, not rheumatologists. Because the patient managing their Sjögren's with a rheumatology team is unlikely to have cranial nerve function formally evaluated unless they present with a symptom dramatic enough to demand it. Because the progressive, insidious nature of early cranial nerve involvement means that by the time the symptoms become undeniable, significant damage has already occurred. This is where the disease reaches into the most fundamental architecture of the body. This is where the stakes become impossible to minimize. Neurological damage can progress quietly. And cranial nerve damage, once it reaches a critical threshold, cannot always be reversed. You were not imagining the swallowing changes. You were not catastrophizing about your voice. Your nervous system may have been sending signals that nobody was trained to receive. Type swallowing in the comments if you have experienced any of these cranial nerve symptoms and never connected them to Sjögren's. Because this is the conversation that needs to happen far earlier than it currently does. The tests that may reveal neurological Sjögren's. These symptoms were never random. And there is a way to investigate them, if you know exactly what to ask for. Brain MRI with specific white matter protocol is the starting point for anyone with Sjögren's who has experienced cognitive symptoms, neurological events, or unexplained psychiatric episodes. Standard MRI may not be sufficient. You need imaging that is specifically designed to detect white matter hyperintensities and cerebrovascular changes. Autoimmune encephalitis antibody panel goes beyond the standard SSA and SSB testing. This panel looks for neuronal antibodies, the ones that target brain tissue directly, and it is the test that catches autoimmune psychosis before it is permanently filed as a psychiatric diagnosis. Autonomic function testing, including tilt table testing, quantitative pseudomotor axon reflex testing, and heart rate variability analysis, documents cardiac dysautonomia and autonomic neuropathy in ways that standard cardiac workups cannot. Skin punch biopsy for small fiber neuropathy and nerve conduction studies for larger fiber involvement together map the peripheral nerve damage that produces the sensory symptoms most patients have been told are psychosomatic. Formal cranial nerve evaluation, conducted by a neurologist with autoimmune expertise, assesses the function of the vagus nerve and trigeminal nerve in patients reporting swallowing changes, voice changes, or facial sensory symptoms. Neuropsychological testing creates an objective documented record of the cognitive changes that are otherwise invisible in clinical settings, and that matter enormously for both treatment planning and medical advocacy. Ask for these by name. Ask, could this be central nervous system Sjögren's? Ask, I want to investigate cranial nerve involvement. Ask, I need autoimmune encephalitis antibody testing. Ask, I want autonomic function studies, not just a standard ECG. You are not diagnosing yourself. You are directing the investigation. And given what you now know about what this disease can do, that direction may be the most important medical decision you ever make. These symptoms were never random. The seizures, the lesions, the psychosis, the cardiac collapse, the swallowing changes. They were never separate problems. They were always one disease, one immune system, moving through the nervous system in ways that nobody explained to you. Look at the comments. Seizure. Lesions. Psychosis. Heart. Swallowing. This community exists because this experience is real. And the fact that you stayed through this entire video means that some part of you already knew the picture was bigger than what anyone had shown you. I created something specifically for this moment. It is called the Neurosymptom Map. It connects every one of the symptoms covered in this video, the neurological events, the structural brain changes, the autonomic collapse, the cranial nerve involvement, and maps them back to the immune mechanisms driving them in Sjögren's syndrome. Type symptom map in the comments and I will make sure you get access to it. Because having the map is the difference between walking into your next appointment with confusion and walking in with clarity. Before you go, there are nighttime neurological warning signs that most people with Sjögren's never connect to the disease. Things that happen specifically during sleep, or in the transition between sleep and waking, that may be the earliest signals of nervous system involvement you will ever get. That is exactly what I am covering next. You weren't losing your mind. Your nervous system was asking for help. And now, for the first time, you know exactly what it was trying to tell you.